from Casey. I am a sports medicine orthopedic surgeon who specializes in knee and shoulder injuries, and I specifically specialize in rotator cuff injuries. So the title of this talk, again, is Shoulder Pain, Your Rotator Cuff Could Be the Issue. So what we're going to go over today, we're going to do a little bit of kind of around the world of the shoulder. I'm going to take you back to school for just a few minutes so we talk about shoulder anatomy, because I do think it's important so you understand the background of what we're talking about. I'm going to focus on rotator cuff issues, and we're going to talk all about them, and it's by far the most common thing I see in terms of shoulder pain. We're going to talk about surgical and non-surgical treatments, and then what you do to make your shoulder better. So as I mentioned, when we think about shoulder injuries, the most common thing that I see by far is rotator cuff disease. And that includes both impingement or bursitis and rotator cuff tears. And we'll talk specifically about what that is. But I am going to talk at the end for just a few minutes about some of the other things that I see in the shoulder that can also cause pain. So if you're logged on and you have shoulder pain and you're trying to figure out what's going on, it's also possible it could be one of these other things. There's labral tears. There's a frozen shoulder, which is a stiffness. There's something called calcific tendinitis. And then there's also shoulder arthritis that could be causing your pain. But again, we're going to focus mostly on rotator cuff disease today. So when it comes to shoulder anatomy, just to give you a little background. So this is a basic anatomy drawing. And the first thing this shows is what I call the beach muscles. So when you go to work out at the gym, whether you're young or old, a lot of times you're working on your pec, which is in the front, or your deltoid. And these are really like kind of the beach muscles of the shoulder, and they are on the surface and they create a lot of the power for shoulder motion. However, underneath those muscles, if you take them off, is actually the muscles of the rotator cuff, which are much smaller muscles. So this is first in the front of the shoulder, what's called the subscapularis, which is one of the tendons. Now, I point out the biceps tendon. That's not actually part of the rotator cuff, but it can be implicated in a lot of shoulder problems because the muscle's further down the arm, but the tendon goes right through the center of the shoulder and can be a source of shoulder pain. But then the other muscles of the rotator cuff, and there's 4 of them, are what's called the supraspinatus, the infraspinatus, and the teres minor. And these all surround the shoulder, and they really help to keep the ball centered in the socket when you lift up overhead. And when we talk about most rotator cuff tears, by far the most common thing I see is an injury to the supraspinatus, which is this tendon on the top. So if you get an MRI report or anything and it talks about the supraspinatus, that's what we're talking about. Now, in addition, when we think about the anatomy, there's also the ligaments. So the ligaments are deep now to those rotator cuff muscles. And those ligaments surround the shoulder and provide stability, and they attach to something called the labrum. And the labrum is the cartilage ring, which surrounds the socket of the shoulder. So some people can also get a tear of this labrum. And again, that labrum is that cartilage ring that surrounds the socket underneath the rotator cuff muscles. And this can be another source of pain or injury in the shoulder. Then there's also what's called the articular cartilage. So the articular cartilage is the lining of the shoulder joint, and it's both on the socket side as well as on the humerus, the ball side, and that's what gets affected in arthritis. So when you get wear and tear of that cartilage surface, that causes arthritis pain inside the shoulder joint. Now, in addition, there's other structures around the shoulder. There's the bursa. The bursa sits on top of the rotator cuff, and that can get pinched when you do shoulder motion, and that can cause pain. So when somebody says they have bursitis, that's really what we're talking about. It's this sac of tissue that surrounds the rotator cuff and can get pinched inside the shoulder, causing pain. So how does this all come together? Well, as you can see, the movement of the shoulder is really very complex and involves the bones. It involves all these muscles and your scapula. So it really can be a very complex motion. So it's no wonder that if any of these things go wrong, it can lead to shoulder pain as you go through range of motion. So what can go wrong when we think about the shoulder? I mean, the muscles themselves can get injured, and that's something we call a strain. So you can sometimes strain those big muscles, the deltoid or the pec, or the muscles of the biceps or the rotator cuff itself. The tendon itself can get injured, and that can be either tendonitis with inflammation or a tear. The ligaments themselves or the labrum can get injured, and that can cause things like a labral tear, or if not, instead of getting injured, they get inflamed, they can constrict down, and that's what causes a frozen shoulder. There's also the cartilage, that surface. That's really what gets affected in arthritis. And then finally, of course, we have the bones in there, and they can get injured in a fracture, but usually that's a traumatic injury, a fall. But you can fracture the humerus, which is the shoulder bone. You can fracture the scapula. You could fracture the clavicle. So how do these injuries occur? I mean, there's trauma with direct falls, as I mentioned. There's traction injuries from lifting at the side. There's a fall directly onto the joint. And then there's just overuse with heavy lifting, and repetitive use, especially overhead, is one of the most common reasons I see shoulder problems, and particularly rotator cuff problems. So how did I hurt my shoulder? I mean, this is what people try to think about. Was it trauma? Was it overuse? Is it just degeneration? Like it just wears out over time. And we also see that not just with arthritis, but also the tendons. And then there's certain things that we see that we like to call idiopathic, which basically means we don't know why it happened and we don't have a great explanation. And some of these shoulder problems are sort of from unknown sources. So when I see a patient and I take a history on everybody, I'm going to ask them a certain number of questions. Did they have a specific injury that started this, or did it just come on over time? When we think about their pain, where is it? I make them always point with one finger because it gives me some very specific information, and you'll see as I go on how that helps me. What activities bother it? Is it overhead activities? Is it activities at the side? Do they get pain at night? Then also, do you feel weakness? Do you feel stiffness? Do you get numbness and tingling, which is sometimes more from the nerves, and that's not usually the shoulder itself. It's either coming from the neck or from the nerves somewhere else. When again, as I mentioned, when I think of the location of the pain, not only do I figure this out on exam, but I ask patients to point. When somebody says it's on the top of their shoulder, that can be more from that AC joint, which is the joint where the clavicle and the acromion meet. When they say it's in the front of the shoulder, it's more likely the joint itself or the biceps tendon. When they say the lateral shoulder, that's really more commonly the rotator cuff. And most patients who see me with rotator cuff problems, they point to the side of the shoulder as the source of their pain, and it kind of radiates down the arm. When I do an examination in the office, there's certain things that are kind of routine for every patient. There's palpation, where I point and feel where it hurts. There's range of motion exam. There's strength exams. And then we do what we call special tests. And this is true almost for any joint that we examine in the office, where we do certain maneuvers to see if it provokes pain, and it can lead to certain diagnoses. So when I examine someone's range of motion, I'm looking how far they can reach it up overhead, how they can reach out to the side and behind their back. There's certain things called impingement signs, which are specific to the rotator cuff, which means when I kind of push their arm up overhead or across their body in a certain maneuver, that typically causes pain with rotator cuff problems. And then I'm checking their strength, which includes something we call the empty can, which really isolates out the function of the supraspinatus, that major rotator cuff tendon. I also look for the external rotation strength, which also isolates out the rotator cuff muscles that are more in the back, the infraspinatus and the teres minor. Then there's imaging, and that includes x-rays, which can look at the bone structure, can look at arthritis or any type of other deformities. And then there's also MRIs, which not only looks at the bone, but looks at the soft tissue structures, including the rotator cuff and the tendons. So you can see the X-ray on the top really just highlights the bones, whereas the X-ray whereas the MRI on the bottom really shows the soft tissues underneath, which we can't see with the standard X-ray. So when it comes to some of the specific things about the rotator cuff, when I'm doing all these things, again, there's 4 muscles and tendons that can be affected with the rotator cuff. And this is the most common source of shoulder pain that I see. And when I think of rotator cuff problems, it's really a spectrum of disease. There's what we call impingement, which I'll go on to discuss, which is pinching of the rotator cuff, but it's not really torn. It's just inflamed as you reach up overhead. Then there's partial thickness tears, which means that some of the fibers of the tendon are torn, but it's not all the way. And then there's a full thickness tear where this tendon is actually torn off of the bone. And these can all be treated differently. So impingement syndrome is a term that we use a lot to talk about the rotator cuff. And it's really a somewhat generic term, which means there's some inflammation of either the bursa or the rotator cuff itself as you lift up overhead. Patients who I see with quote unquote impingement syndrome have pain with overhead activities such as sports or work. It's almost always worse with repetitive use. And sometimes these patients can get pain at night as well, especially if they sleep on that shoulder, it causes pain. So then there's rotator cuff tears, which is a more significant form of the disease. Sometimes I see that with trauma, including heavy lifting or traction or a fall. More traumatic events many times cause immediate pain or weakness in the rotator cuff. But I will tell you that I see rotator cuff tears every day. And many of these patients just come in with degeneration and chronic pain over time. So just because you have a tear does not mean you had some type of traumatic injury that caused it. Patients with a tear have very similar symptoms. They have pain with overhead activity. They also get night pain, which is very common, but they can have weakness on exam or functional deficits, which sometimes we don't see with tendonitis. So how do I tell the difference when I see somebody with tendonitis or a tear? Sometimes it can be hard, quite honestly, but I look at their history. Did they have a traumatic injury, which makes me more suspicious of a tear? Do they have that night pain, that pain that wakes them up from sleep? That's very common with a tear, more so than tendonitis. Again, I examine them, and if they have weakness, I'm way more suspicious that they may have a tear. And then, of course, there's an MRI, which can help us to really look at that tendon to see if it's torn off of the bone. So for when I see patients, when do we order x-rays? We really get x-rays in everybody, okay? The first time you come into my office, I am getting an x-ray. Now, if somebody just has tendonitis, it ends up being normal. And then sometimes a patient will say, why did you get an x-ray? Why did you need the x-ray if it was normal? Well, I need to show it's normal to make sure I'm not ruling out something else. Sometimes somebody can have a fracture that we didn't see. Sometimes somebody can have arthritis that we wouldn't diagnose if we didn't have the x-ray. There's bone spurs that we're looking for. Sometimes you can have a calcium deposit that we wouldn't see without the x-ray. So there is a purpose to this, even when it's normal, because then when I know it's normal, I can rule out all those other things that could be a source of somebody's pain. So what about an MRI? You know, of course, I get patients all the time, and many times they just want to get an MRI to see what's going on. Well, usually I have to have a reason to get an MRI. And the reason for me is if it's going to change my treatment. So if I see someone who had a significant traumatic injury and I'm really worried that they tore the rotator cuff when they fell, I'm going to get an MRI. If somebody has weakness that really concerns me, and again, I'm worried that that weakness is from a tear that could need to get fixed, I'm going to get an MRI. Now, the other thing is, if I treat somebody without surgery and they don't get better, well, then, of course, I want to get an MRI to make sure either I'm not missing something, or have a better diagnosis, or potentially change my treatment plan at that point. So with an MRI, what do I use it for? It can be for diagnosis of a tear. It can be for preoperative planning or preoperative counseling, which is really one of the most important reasons to get the MRI. So if I have a patient who I know I'm going to treat conservatively for their problem, I don't necessarily need an MRI to be able to do that. So I really use it as a pre-surgical tool for me when I know that this is something that potentially needs surgery. And this, again, can be a difference between a small tear or a really big tear, and it helps with counseling my patient on what I recommend. So what kind of conservative treatment can we do for either tendonitis or a tear? It includes anti-inflammatory medications, both over the counter or by prescription. There's rehabilitation exercises for both rotator cuff and this, what we call the scapular stabilizers, which are muscles that power the shoulder blade. There's something called posterior capsular stretching, because a lot of times people can get stiffness. And the question is, how long are we going to do this before we sometimes get more aggressive or start changing treatment? I mean, it used to be that for strict tendonitis, we talked about doing this for 9 months before we'd ever consider something more aggressive, especially surgery. And then we kind of have, decreased that sometimes to 6 months, 3 months. But I can tell you that for tendonitis, we almost always treat this conservatively for a very long time before we're ever going to consider anything like surgery. So again, what's the purpose? It's to control inflammation, including rest, avoid overhead activities, provide range of motion and prevent stiffness, and many times anti-inflammatory medications all can contribute to controlling inflammation. The goals of rehab, it's to improve scapular mechanics, which are, really provide the kind of the base for your shoulder motion. Is to strengthen these rotator cuff muscles and improve the mechanics. It can include core strengthening, because that can all improve the mechanics to make this better. I mean, we take baseball pitchers who have full thickness rotator cuff tears, and we strengthen everything around it, and we get them back on the mound, pitching 90 miles per hour or 100 miles per hour. What about cortisone injections? This can be someone who comes in and really has significant pain and says, please do something to try to calm this down. We can use cortisone injections. It can be for someone who has a failure of therapy initially, and then we want to consider cortisone. So cortisone, for those who aren't familiar, is really one of the most powerful anti-inflammatories we have. And it's putting it locally. So I like to tell my patients, it's like putting 100 Advil kind of right in the area of the problem to try and calm down that inflammation. And I almost always use it as an adjunct to therapy. So if a patient comes in and they say, I'm in a lot of pain, can't you give me an injection so I can go on my way? I'll do it, but I tell them they have to do the therapy. The injection helps the pain, but the therapy is what cures the problem. So it's really crucial to try to use it in combination to make someone better. And otherwise, they're going to get an injection, they feel better, and then they come back to see me a few months later because the pain returns because they didn't improve the mechanics. So who do I send for conservative treatment? I mean, this is really nearly everyone. Anybody who comes in to see me with rotator cuff tendonitis or bursitis, I'm going to send them for physical therapy. We're going to talk about anti-inflammatories. We're potentially going to do a cortisone injection to try to help this. If someone I know has a rotator cuff tear and it's big and it's chronic, I will many times try and treat them with physical therapy and injection for sure, try to regain the balance of their shoulder. They don't necessarily need surgery, and they may not do as well with surgery. So we're going to try to treat them conservatively. So what's the success rate? I mean, there's been multiple studies that show it can be successful both for tendonitis and people with full thickness rotator cuff tears. And one of the most important things is patients with full thickness rotator cuff tears can improve with conservative treatment. Now, that doesn't mean that there aren't certain patients that I really recommend surgery for, and I do a lot of rotator cuff surgery. But one of the most common things that patients will say to me is, well, if I have a tear, how is therapy going to help it? Well, it is not going to heal their tear. That is true. And I tell all my patients it does not heal your tear. But by improving your mechanics, we many times can improve your symptoms so that you do not need surgery. And it's been shown in a multitude of studies in the orthopedic literature that if you get an MRI of every patient over a certain age, over 40, over 50, over 60, over 70, who have absolutely no symptoms, and you're giving out MRIs for free at the mall, and you just get an MRI on everybody, there are a lot of patients who have partial thickness and even full thickness rotator cuff tears who do not have any symptoms. So what that tells us is that we can potentially take somebody with a full thickness tear and we can make their symptoms go away. And if we make their symptoms go away, they may do just fine, especially in certain settings without surgery. So when do I decide? I mean, I am a surgeon. So when do I decide to do surgery? I mean, I love doing surgery, so I'm not going to try and tell you that there isn't anybody that we want to do it on. So when do we make this decision? It has to do with age and activity level. It has to do with how long you've been having symptoms. It has to do with whether or not this is what we call acute or chronic. So if somebody falls and completely tears the rotator cuff off the bone and can't lift their shoulder, yes, that does really well and better with surgery. So I'm going to recommend fixing it. But some patients with chronic rotator cuff tears, it's much better to try to treat them conservatively. It has to do with the quality of the tissue. Is this going to be a nice, healthy rotator cuff that I can get to heal? Or is it a tendon that may do poorly with surgery because it's really degenerated? And sometimes it has to do with patient expectations. You know, is this somebody who I reliably think I can make better? So again, when do we do this? Acute full thickness tears, chronic tears that don't do well with conservative treatment. Occasionally it's persistent impingement, but I can tell you this last category is very rare to have somebody who doesn't have either a significant partial thickness or full thickness tear that I need to take to surgery. How do we do it? I mean, in my hands, it's pretty much 99% done arthroscopic. That means we do little poke holes. We have a camera, as you can see in the background here. There's a video that's up there. And so we, you know, through this video are able to do all the surgery through these little poke holes. It's nearly always outpatient surgery. You go home the same day. So that's, you know, certainly very convenient for patients. We've really advanced over the course of time with almost everything we do when it comes to rotator cuff repair. We used to do something called a single row repair, which means that basically we fix it in one spot. We've now, you know, really advanced, and the overwhelming majority of me and my partners do something called a double row repair, where we fix it in two different spots to increase the security. We've increased pain control after surgery. We've improved our rehab methods. So we're always researching this. And, you know, one of the things I pride myself on is running our research program at Rothman for sports medicine. And, you know, we really look at all these things carefully to try to, you know, make the best outcome for our patient. So this is just a sample, and I'm going to show you a little video of what we call a double row rotator cuff repair. This is an arthroscopic picture. And on the left, there's a hole in the rotator cuff. And on the right, it shows my you know, my suturing technique to do what's called a double row rotator cuff repair, which ties this down to allow it to heal. And then once it heals, then somebody's got a rotator cuff that really functions well. My mother is very proud of my sewing technique. She actually happens to be a home ec teacher. And, you know, this sort of looks like some of the stuff that she used to teach to her students here. So this is a rotator cuff repair. So this is a torn tendon, and I'm pulling it. That's my little grasper. This is actually doing something called an acromioplasty, which allows more space. This is, you know, in very fast time, this is putting in an anchor. These anchors have sutures, so that's the bone. And now the tendon has to get reattached. So this is using a little spear device that I use to pass the sutures through the tendon. There's a variety of techniques I use to pass the sutures through the tendon to be able to tie it down. So now all these sutures from the anchor are placed through the tendon. Then once they're placed through the tendon, I'm able to tie these doing what's called arthroscopic knots. So we have a little knot pusher, which is like an extension of my finger. I tie all these sutures down. So now it's tacked on the first row of the rotator cuff repair. Then we're able to attach this to a second anchor that really makes what's called the second row or the double row to really be able to compress what we call the footprint of the rotator cuff. And this allows that tendon to be tied in two different places. So now it's tied in two different spots and the rotator cuff's repaired. And this is another example of a double row rotator cuff repair. Rotator cuff repair takes me approximately a minute and a half, as you see. No, this is, you know, about an hour of surgery to be able to you know, evaluate the joint and repair the rotator cuff. What do we do after surgery? So I have a couple of different protocols depending on the size of the tear. My patients are in a sling typically for about 4 weeks. For the first 6 weeks, we really have to protect this. When I start passive motion, meaning they're allowed to kind of use it with the therapist, depends on the size of the tear, either at 4 weeks or initially with small tears right away. Then really from the 6 to 12 weeks, we start increasing motion to full, we start progressing to active motion. And I tell people it's between 2 and 3 months to be able to start doing things overhead. Really after the 3-month mark, we get people more functional. And it really takes 4 to 6 months for people to get more, really more sport specific, or if they need to strengthen for work. And it really takes about 6 months to, gain your strength. And when you look at the outcomes, strength can improve all the way up to 12 months after rotator cuff repair. It's really up to about 80 to 90% in the first 6 months, and it can take really up to a year to get to up to that 90 to even 100% of strength. Now, what about some of the other things that can go wrong in the shoulder? And then I'm going to answer everybody's questions that they may have about, rotator cuff injuries. So as I mentioned, there's also the labrum, which is the cartilage ring, and that's where the ligaments attach. And you can tear this either in the front, anterior, in the back, posterior, or on the top, what's called a superior labral tear or a slap tear. What do people complain of with labral tears? It can be catching in the shoulder with certain movements, pain with overhead activities or lifting. People, especially at a young age, can get instability either in the front or the back of the shoulder. And again, the most common would be either an anterior or something we call a Bankart tear, superior or slap tear, or posterior. So this is someone who dislocated their shoulder, and this typically happens from falling with the arm outstretched. It usually happens to the front and their arms kind of out to the side. This is what somebody with shoulder instability looks like. So I can actually dislocate this patient's shoulder under anesthesia. And that's what it's like to have significant shoulder instability. Sorry if anybody's eating dinner. And this just shows, again, this is arthroscopy. This patient's actually on their side, but they have a complete tear of their labrum. This is inside the shoulder joint. This is the top of the shoulder where the labrum's torn off the top. Then that's the ball where the probe is pushing on the ball and socket. And as we look down, this entire cartilage ring is torn off of the socket. And this is what happens with somebody with significant shoulder instability who gets a labral tear. But some older patients can have labral tears causing pain that don't cause significant instability. When I have to fix somebody's rotator cuff, again, someone's labrum, we have to protect it for the first few weeks. Then we typically start them in physical therapy to work on range of motion and strengthening. Similar protocol, but it's a little more accelerated, about 12 to 16 weeks for strengthening in the gym. And really, it can take 4 to 6 months for full return to sports after a labral repair. What about adhesive capsulitis or frozen shoulder? So the connective tissue, the ligaments sometimes get inflamed and they tighten down and cause scarring around the shoulder. And this can lead to a restriction in motion. The major symptom that patients have with this is stiffness, but in the early part of a frozen shoulder, pain can really be the most predominant complaint. And sometimes we see people before their shoulder even freezes, and that causes a pain without the stiffness. What happens? Why does this happen? Most cases, again, this is what we call idiopathic. We don't know, but there are certain diseases that are associated with a frozen shoulder. There's diabetes, there's some thyroid disease, other medical conditions. Sometimes it's somebody who immobilized their shoulder for a period of time, either from an injury or possibly from surgery. How do we treat this? This is almost always treated with physical therapy to stretch. Sometimes I do use injections in the shoulder joint as an adjunct, and I can get the overwhelming majority of my patients 90% better with physical therapy and injection. Sometimes we do surgery to release the capsule, this tight tissue, if somebody has persistent stiffness. What about calcific tendinitis? This is basically a calcium deposit that forms around the rotator cuff tendon. They can present sometimes just like rotator cuff tendonitis, but sometimes I see patients who have absolutely the most severe shoulder pain. These are patients that go to the emergency room, they wake up one day and all of a sudden they can't move their arm, severe pain. And this is very common for calcific tendinitis. We don't know why this happens or why it causes such severe pain, but it's very typical for this. Many times these deposits resorb over time and sometimes the pain just calms down. Again, the cause is mostly unknown. The treatment for this, again, is an injection and physical therapy. The injection can really make patients better. If I see someone with calcific tendinitis, I kind of jokingly say that they want to kiss me because I can make them better almost immediately. Sometimes this also can get aspirated under ultrasound. I have some of my partners, including my non-operative sports medicine partners, who can use ultrasound to find a deposit and suck it out. And then sometimes we do surgery to get rid of that deposit and then repair the rotator cuff, but this is less common. Then there's finally shoulder arthritis. So osteoarthritis, just like any joint, can occur in the shoulder. This can be from just quote unquote wear and tear or use over time or trauma. There's really two types of arthritis I see in the shoulder most commonly. There's AC joint arthritis, which is on top, can cause a bone spur or prominence on the top of the shoulder and causes pain in that area. And then there's what we call glenohumeral arthritis, which is the actual shoulder joint itself. Then finally, there are people who we see with rheumatoid arthritis. If you have rheumatoid arthritis, you most likely know it because it affects many joints. It's a systemic problem and it's really an autoimmune disease. And then this attacks the connective tissue around the joint. Again, AC joint arthritis, that causes pain with motion. It's directed right on top of the shoulder. It's typically from wear and tear or repeat overhead activity. Sometimes it's aggravated by a fall and people have pain on top of their shoulder. We can diagnose this by both physical examination. When you bring somebody's arm across the chest, results in pain, or it can be tender to touch. An X-ray helps us in this case. Treatment is typically an injection or physical therapy. And it's really rare for this to require surgery, but sometimes we do surgery to remove the end of the clavicle bone so it doesn't pinch in there and cause pain. Then finally, there's glenohumeral arthritis. So glenohumeral arthritis is wear of the shoulder joint itself. Less common than other weight-bearing joints, but we do see plenty of shoulder arthritis in a shoulder practice. Bone-on-bone contact leads to development of bone spurs and pain. You can get weakness of the rotator cuff muscles, usually secondary to this. And there can be pain and loss of motion. And then this can have both mechanical causes, again, wear and tear, prior surgery, or potentially medical causes. How do we treat this? Initially, conservatively, ice heat, anti-inflammatory medications, physical therapy. As I mentioned, medication, most commonly non-steroidal anti-inflammatories, activity modification. This can be treated with injections, and this includes everything from cortisone injections. There's viscosupplementation, like is done in the knee joint, which is basically what's joint grease injections. And then there's also something called PRP, which is a blood product where blood gets taken from the patient. It gets spun down into what I like to call healing juice and injected into the shoulder. But those last two things have an out-of-pocket expense associated with them. And then finally, there's shoulder replacement, where you actually replace the joint. So when we think about total shoulder replacement, that's basically for advanced arthritis. It's not relieved by other options. We'll replace the ball in the socket with metal and plastic components, and this can restore pain-free motion. And then finally, there's something called a reverse shoulder replacement. The indications for this are something we call rotator cuff arthropathy, which means not only does somebody have arthritis, but they have no rotator cuff, and that leads to poor mechanics that can wear out the shoulder joint. Sometimes we do it for somebody with a massive irreparable rotator cuff tear, and these patients typically have both pain and weakness. We like to reserve it for our older patients, and it can have a relatively high complication rate. This is just kind of a schematic of what a reverse ball and socket is. So the ball's put where the socket normally is, and the socket's where the ball should be. So that's why we call it a reverse ball and socket. And then finally, this is what an X-ray looks like for what we call an anatomic total shoulder. So the one on the left really looks the way a shoulder is supposed to, with a normal ball and socket. And then on the right, the ball again is where the socket should be, and then the socket's where the ball should be, and that's a reverse total shoulder. So finally, what can I do? Okay, so, really, I think the most important thing is to get a proper diagnosis. If you're out there listening and you have shoulder pain, even though I'm discussing the rotator cuff most importantly, as you see, there's other things that cause shoulder pain. So I think you really need to make sure you get a proper diagnosis so your treatment can be tailored to help make the problem better. Preventive stretching and strengthening. There's a commonly available conditioning program. It's really available through the American Academy of Orthopedic Surgeons, which can be a great resource. And it has a lot of the stretching and strengthening exercises. So if you say, look, I hate doctors, I don't want to see doctors, I don't really like Dr. Friedman, he doesn't sound like he knows what he's doing, you can go on there, you can just get a basic program for some stretching and strengthening just to start out with something at home if you want to do something without getting, a full diagnosis. But again, I sort of resort back to number one, which is to really tailor your treatment. You should get a proper diagnosis for your problem. And I would just say, take charge of your health. If you're having shoulder pain, don't let it interfere with what you love to do. We can make it better. And again, even though I'm a surgeon, we have a lot of things that are non-surgical that we do to make most of our patients better before they ever need to consider it. And that's all for my formal presentation. I hope everybody learned something. And I'm going to go to Casey, and we'll get to the Q&A, and hopefully we can answer people's questions. And, if anybody wants to get seen, I'd be glad to see you, or you could always see one of my partners as well.
Thank you, Dr. Friedman. You gave some really, really good advice, and you covered a lot, and I appreciate that. I know our viewers do. Real quick, one of our attendees on here did just want to make sure you saw that he gives a big thanks to you because he is a patient of yours. You repaired his rotator cuff last year, and he's already back to swimming and rowing, and he's 100%. So just wanted to thank you for that.
That's great. Thank you. A little testimonial. There you go.
Right?
I appreciate that. Thank you.
So again, anyone who has questions, please type them in the Q&A. Try not to make them too specific, but we'll try and get to as many as we can. Also, if you wanted to make an appointment with Dr. Friedman, he is seeing patients out of the Bryn Mawr and Chalfont office. And the phone number is 610-480-6584. All right. One of the questions is, I was diagnosed with rotator cuff disease on my right shoulder, and a year later, a frozen shoulder on my left. Symptoms to me were identical. Thoughts?
Well, okay. That's an interesting question, because really the question becomes, of course, are both of these diagnoses correct? And they absolutely could be, because people can have different problems on both sides. But as I mentioned in the little slide I gave about a frozen shoulder, is that it is not uncommon when somebody has a frozen shoulder to have symptoms that look like rotator cuff tendonitis before the shoulder freezes. So even I sometimes will see someone and I diagnose them with rotator cuff tendonitis because that's what it looks like, because their shoulder hasn't frozen yet. And then they come back and I go, man, I was wrong. You really have a frozen shoulder, because now it's finally frozen. And you have to be careful sometimes with that diagnosis. So, I think the real important part of the story that you ask, again, goes back to my last slide, point number one, which is the diagnosis is crucial for treating the problem, because rotator cuff tendonitis and frozen shoulder are really treated differently, and the therapy is different. So it's important that your program is tailored towards your diagnosis. So hopefully the diagnosis was correct on both sides. And then that way, when you have a frozen shoulder, we do one thing where we're stretching it, possibly injection. And when you have tendonitis, it's a lot of strengthening, improving the mechanics. So again, it kind of goes back to I can't speak specifically if like all your everything you did was correct. And hopefully your shoulder pain is resolved on both sides. But if it hasn't, it's worth like sort of revisiting and making sure that at this point, the diagnoses are correct so you get the right treatment.
Thanks. Next question. What % of mild to moderate RC tears get better with PT only without surgery?
That's a great question. And the answer is a lot can get better. I mean, when you say %, I mean, it's somewhere, if you look at the literature, between about 50 to 70% can get better with conservative treatment without needing surgery. Now, the caveat is that all these tears can be different, okay? They really can. And again, if somebody has an acute tear with a lot of weakness, that should get operated on. And there's certain situations where we are really worried about a tear progressing to get worse. But if somebody comes in with no trauma and they have shoulder pain and they happen to get an MRI before they saw me and they have a rotator cuff tear, that's exactly what you described, mild to moderate. And they say to me, Dr. Friedman, can I try and treat this conservatively with physical therapy plus minus a cortisone injection? The answer is yes. And many times I actually encourage it. And one of the really interesting parts about that is that if you look at the patients who do well over 6 to 12 weeks with physical therapy, they don't have symptoms when they come back to see me, they actually typically continue to do well for a long period of time. And typically the rotator cuff tears don't progress and they continue to not have symptoms. If you don't do well with that initial treatment, you typically end up getting surgery because you didn't do well, you continue to not do well. So there is almost no harm in trying that initial conservative treatment. Now, again, there are exceptions, but that's why it can be a very good way to go initially to see how you do. And then there's certain things we sometimes do to monitor, make sure your tear is not getting bigger or progressing or more weakness or anything else that would make it harder to fix. And I hope that answers your question, but it's about 50 to 70%, and they can end up doing well for a long period of time.
Thanks. Would you recommend against doing push-ups for older people as they are hard on the shoulder muscles?
No, it's interesting. It can be, we always hear these controversies on which exercises are good and which exercises are bad. I mean, it obviously depends on somebody's age and overall fitness level, but in general, body weight exercises can be self-controlled and can be good exercise for people. The thing that becomes important is that you don't want to like dominate certain muscle groups and ignore others. So if somebody is older and they still like to go to the gym and they're, again, doing quote unquote beach muscle exercises, pushing exercises, bench press, whatever, they really have to make sure they're also strengthening these little tiny rotator cuff muscles that are underneath, because if you don't, that's where you're going to get into a problem. But if you're doing some basic rubber band exercises and things to strengthen and keep the mechanics good, then it's okay to do those other pressing exercises, particularly if it's with light weight or body weight.
Great. And along that line, is it possible to return to lifting 20 to 50 pounds overhead after a rotator cuff tear?
Absolutely. I'm sorry. Let me make sure I understood that question. That question was, after rotator cuff repair, can you get to the point that you can lift that weight? Is that what the question?
Yes.
Yeah. I mean, everybody is different, but the goal of my surgery is to get people to 100%, which means no restrictions, whether they had a work injury, whether they fell on it, whether they're young or old. Now, I'm not going to tell you that 100% of my patients get to 100% because that's not realistic. And there's different factors prognostically that's going to affect where people get. But when you say in general, like, can we get patients back? Absolutely. I mean, again, our goal is to get patients back to everything, including heavy lifting, whatever that capacity is.
Okay. How does a tear or weakening in the supraspinatus tendon lead to a tear or weakening in the long head bicep tendon?
Okay. Well, they don't lead to each other. So as you saw, again, that's somebody who's been studying their anatomy or looking at Google or they've learned a heck of a lot from my lecture, right? But if you go back to the beginning, as a matter of fact, I could probably do it somehow. What you see is that the long head of the bicep sits right in the front of the shoulder, and then the rotator cuff kind of surrounds it. So they don't, like, one doesn't lead to the other, but they're commonly associated with each other in having a problem. And if your mechanics are bad in one, they kind of affect the other. So someone who has a full thickness rotator cuff tear very commonly has biceps pathology because they both get kind of pinched underneath the acromion, that bone. They both get degenerated similarly, and the mechanics in one, again, can affect the other. So it's very common for me to see people with rotator cuff problems, and especially the ones I operate on end up having a problem with their biceps that I also need to treat as well. So I hope that answers your question. They're not necessarily causal together, but they're associated with each other because they live like right in the same zip code.
Okay. What causes the shoulder to make popping noises when it moves? The shoulder does not hurt, but always makes a noise when I rotate my arm.
Again, it can be a tougher question to answer because it can be a few things. It could be anything from the biceps tendon, which lives right in the front. It can kind of slide around a little bit. The labrum, that cartilage ring, can sometimes cause popping or clicking. The rotator cuff itself can have a tear that can cause popping and clicking. But I will tell you one thing. And almost all orthopedic surgeons have a very similar philosophy on this. If you have, I mean, there's certain popping and clickings that we have to take seriously because they mean something bad happened. But in general, if somebody comes in to see me and they say, I have this noise in my joint, whatever that joint is, but I don't get any pain, and they don't have any other associated symptoms I worry about. They don't have instability. They don't have, swelling. They don't have weakness. We kind of ignore it, because we don't ever do major things most of the time because somebody just has some form of noise in their joint. Now, sometimes maybe we'll send them to physical therapy if it's a mechanical, it's something that can help with the mechanics and stuff. So there can be, the answer to your question is there can be a variety of reasons you get that noise, but it's not necessarily something we're going to really target aggressively to treat if it's your only symptom and it's not causing associated pain.
What do you think of chiropractic as one approach to conservative treatment?
I absolutely think that it can help. It can help for a variety of reasons. Number one, a lot of people I see with shoulder problems have associated neck problems, and certainly that from a chiropractic care is good treatment. In addition, many chiropractors who are skilled can do everything from therapy to massage to some stretching to all the things that a lot of therapists do to try to help. So it can absolutely be an adjunct. So it's not necessarily always primary treatment. And some of the things that, as you saw, again, I'm a surgeon, so I like to talk about bad problems because bad problems come to see me and I treat them, when they are bad with surgery. But one of the first things on another one of my first slides says, what kind of things can go wrong? And sometimes it's just the muscles, the muscles are just sore. There's a muscle strain. It's overworked. And, chiropractic care can really help to calm that down and get people better before they ever have to come see me.
Okay. Let's see, what do you think of the new balloon insertion?
That's a very good advanced question. So when I talked about the rotator cuff. I talked about rotator cuff repair because that's what I primarily do for my patients. Okay. But I didn't talk a lot about rotator cuffs that aren't fixable, which is really an advanced topic. And I'm trying to cover a lot in a seminar here. So if somebody has a rotator cuff tear that's massive, their whole tendon is torn, and it really can't be fixed because it's degenerated or it's been retracted for a long period of time, or the muscle is shrunk, then sometimes what we're trying to do is figure out what are our other options, because I can't get this tendon fixed. Okay. And there are a couple of options that exist for those patients. One of them is what was just mentioned, which is a balloon spacer. And a balloon spacer is basically putting in a device kind of in the space where the rotator cuff used to be, and it gets inflated. And and basically what it does is it depresses the humeral head to allow someone to try to retrain their shoulder through physical therapy, even though that rotator cuff isn't there, and then decrease their symptoms. And it can work in certain settings, and it can be a reasonable option for certain patients who are trying to avoid a reverse shoulder replacement, which is also something I kind of mentioned at the end that can be an option for somebody who has a massive rotator cuff tear. There's also something that's another complicated surgery called a superior capsular reconstruction, which is like putting in a patch to also try to replace the rotator cuff. So there's, all kinds of things I didn't mention in a very quick, brief talk where I'm trying to make it sort of garden variety for whoever might be in this audience, and I can't see you. And I don't know if you're sleeping or drooling or watching TV or already signed off, but there are other treatments that exist, and the balloon spacer is something that can be applicable for certain patients, and it can work. But again, that's something that really needs to be discussed specifically, like kind of with your surgeon.
I would like to know if during surgery, do you use the patient's own stem cells borrowed, donated from a piece of their damaged tendon or cartilage or another part of their body to enhance improved surgical outcomes?
Wow, you guys are asking some good questions.
These are, yes.
Kelly, I got it. Are there a bunch of other my partners out in the audience trying to, ask me these tough ones? All right. So here, what you're really asking is what can we do to try to help the rotator cuff to heal? So again, this is an advanced kind of topic that, in a half-hour quick lecture, I'm not going to talk about, but there's a lot of things that we can do to try to stimulate that rotator cuff to heal when we do surgery. We try and get to a nice set of healthy, fresh tissue. We make sure the bone has got some bleeding. Sometimes I even do something called a microfracture where I poke holes to really just help bring in marrow elements to help that rotator cuff heal. And of course, the way that I secure it is important. But to answer your question, there have been a lot of studies that have tried to look at whether or not, number one, PRP, which is a blood product, which is used where we take your blood and spin it down and we put in something called platelet-rich plasma to see if that enhances rotator cuff healing. There are studies that are trying to look at mesenchymal, quote unquote, stem cells, which involves bone marrow aspirate, which is really the only thing in the United States that's available for getting, quote unquote, stem cells, even though it has some other things in there too, to try to stimulate healing. And what I will tell you is the real answer is that none of these products, other than the things we do surgically to bring in marrow elements, like I said, to abrade the bed, to potentially microfracture, which brings in marrow elements, but things that are like adjuncts to surgery, PRP, to date, it really hasn't been shown to increase the rate of rotator cuff healing. And it's something we're studying very hard. And I, also am very involved in our biologic research here at Rothman, but I don't currently use those products during surgery because it hasn't been shown to increase healing to date.
Okay. So who at who uses PRP at Rothman? We have providers that.
Yeah, I'm sorry, but that was a different question.
Oh, I'm sorry. There is a next question. The next question.
I'm sorry.
Yeah.
So yeah, so I am one of the providers who uses PRP. I want to make sure I don't mix questions here. The question that was asked is if I use it at the time of rotator cuff repair to improve healing. The other question is, do these things help with non-surgical care, which is also controversial, okay? There is some data that says that PRP can be used for chronic rotator cuff tendonitis and possibly for tears. It has not been shown to heal the tear, but in terms of relieving symptoms, there is some data that it can work. And I am actually a provider who uses PRP in my practice. It's something that I do right in the office where my physician assistant actually draws the blood. We spin it down right in the office, and then it can be injected. Sometimes we use ultrasound, and sometimes you don't need it, because I inject all the time and I know how to put it into the joint or around the rotator cuff. So those are things that can be done. There are certain providers that do it, and I am one of them. So that's certainly something that we can help you with. And I also don't know who on this call is sitting within a 2-mile radius and who is on the call from Southern California. So if you live real far, there's probably a local provider that can help you with a lot of these things. And certainly if you're near my areas, I'd always be glad to help you.
Thank you. If there is a sound of bone on bone crunching, even if it doesn't bother the person, should they avoid that movement? Does that mean cartilage lost or?
Yeah, I mean, certainly based on that quote, it is most likely arthritis. And when somebody says they feel bone on bone, it certainly can be bone on bone. And typically when you have arthritis as the source of your pain, if you do things that tend to aggravate it from pain or, really create, a lot of noise crunching, then yes, in general, those are activities that we try to avoid. I mean, in general, we try and stick with, lighter, lower impact things. When it comes to the shoulder, when we think lower impact, any kind of, heavy lifting, that's going to be a higher impact. Things that are gently working on motion or gentle strengthening, swimming, these are typically good exercises. So yes, I would in general try to avoid those activities that aggravate it.
Right. Somebody did ask, with so much talent at Rothman, with the same specialty, how does one go about deciding on the doctor? And I would say what you're doing right now is exactly how you would decide. You do your research, you listen on these programs, you get word of mouth recommendations. Any other thoughts, Dr. Friedman?
Yeah, I mean, look, I'm surgeons aren't known for having small egos. That's not our strong suit. I mean, I'm, of course I'm going to sit in front of you and tell you how great I am, but I will tell you that one of the things I love about being at the Rothman Institute is how I'm surrounded by a lot of other great people. So I take care of a lot of shoulders, and I think I do a great job of it. And, I want people to feel comfortable with me. But I'll tell you, if somebody comes to see me in the office and they ask that exact same question, they saw one of my partners, Dr. X, and I'm going to tell you that they're great too. And they're going to take great care of you also in the overwhelming majority of cases. So it's a comfort issue. And I think that Casey said it well. You just have to feel comfortable. You kind of do your own research. And, we thankfully have a lot of very capable people who do a great job. And that's just a tribute to our practice.
Great. I would say we have one more question. If you could give the single best exercise for a partially torn rotator cuff, what would it be?
Yeah, I mean, that's a little bit of a loaded question because I'm going to tell you honestly, there's not one exercise that I'm really going to be able to say, and I'm not avoiding your question. I'm just telling you, and I can tell you, it's kind of like, not only do I, own the, the Hair Plug Institute, but I'm a customer. I have a partial thickness rotator cuff tear myself. And I went to formal physical therapy to get a set of exercises to try to help strengthen everything around it, including my scapula, including the rotator cuff. And I really found that that combination of things helped. So I don't want to tell you that I can give you the one magic bullet that is going to make it better, because it really is a combination of strengthening activities and stretching that will make it better over time. And it requires some investment, and it's a pain for all of us to, anybody who has an injury, none of us like physical therapy and these things we have to do to make it better. Everybody just wants to be better, but it really is a combination of activities. So I'm sorry that I'm not answering it perfectly, but it includes strengthening the scapula, strengthening those rotator cuff muscles, doing some stretching, including what we call the posterior capsule, and all that combination is what's really going to make that better.
Great. Thank you again for taking the time to be on here tonight, Dr. Friedman. And thank you all that attended. Again, I will be sending this out so you can reference it in the future, probably in the next day or two. So if you have any questions, you also have my information, and the line to make an appointment is, again, 610-480-6584. And we hope you all are doing well and have a good evening. Thank you, Dr. Friedman.
Thank you. Thank you, everybody. Thank you for everybody's attention and some great questions, even though I can't see out there. Take care.